like to chime in on that notion after she's done. But without further ado, Dr. Cogswell, go right ahead. Gang, I can tell you, I've looked at the slides. There's really great info here. So,
Well, I mean, it's all info that you can find other places as well, but you could probably spend your entire day reading about this and getting, deeper and more scared all the time. So I'll try to let you know what I know to be true and where the limit of that knowledge, takes us and what I kind of see happening in the future. So again, COVID-19 consideration for heart transplant patients. This is a little bit more geared towards transplant, I would say, because Glenn is reaching out as a transplant patient, and I know we have a lot of transplant patients, but many of you have had VADs as well, and there may be some VAD patients here as well, so it kind of pertains there as well. So we're gonna go through some COVID-19 facts and stats. We'll talk about, what we did at the University of Minnesota among the advanced heart failure team very early in the pandemic and kind of bringing it to now to try to keep heart failure patients and transplant patients and VAD patients safe and to try to keep our team members without getting infected as well. Because if we all went down at the same time and got COVID-19, we wouldn't really be able to provide care either, which would be bad. So we had to come up with a lot of strategies around that. We know a little bit about how transplant patients and specifically heart transplant patients are doing with COVID-19, and I want to go through some of that with you. I can talk a little bit about what some of the therapeutic targets, and what I mean for that is what are the treatments for COVID-19 right now? What is the evidence that's coming out, and are we making any headway in terms of outcomes? And I think the biggest question facing a lot of our patients and a lot of our clinic visits these days are, society's opening up. Should I venture out? Is that a very dangerous thing to do? Should I get a haircut? What about the grandkids? Am I literally supposed to stay in my house until there's a vaccine? How do I cope with this? And I would love to tell you that I have every answer of exactly what you should do. So we'll try to go through that in a little bit more detail. And then also just a little bit, according to Cogswell, what I see happening next with the pandemic. Okay, next slide. So we know more about how the virus spreads now than we did. If you remember back in sort of January and into February and early March, is it spread through kind of respiratory droplets the way that influenza is, or is it spread? There's a pathway called fecal oral where literally virus would be in the stool and it might get on some food. Could you ingest it and get it that way? Is it what we call aerosolized and little tiny particles that we breathe out? It was hard for us to really, does everyone need to have an N95? And probably you've read a lot about this at this point. We have cloth masks, and then we have surgical masks, and then we have N95s, which is, filter out 95% of particles. In even the WHO and the CDC were kind of changing their guidelines, and what we were doing in the hospital was changing week to week. You don't need a mask. Okay, masks are bad. And there's a lot of information on the internet these days. And so, on some level, 50 years ago, if this was happening, on some level, we're helped by having a lot of information out there, but on some level, you can really start to get yourself down a rabbit hole of information. What I'll tell you right now is we think largely it's spread by person-to-person contact, people who are probably within 6 feet of another, mostly spread through respiratory droplets. So you have an infected person who coughs, sneezes, or talks, and basically those respiratory droplets get near the mouth's nose, or people nearby, possibly inhaled into the lungs. And then the kicker with COVID-19 is that people are having virus within their respiratory tract before they know that they have symptoms. That is the reason that this virus has spread the globe as quickly as it is. If you didn't have virus coming out of your mouth and nose until you knew you had a fever or a cough, we could isolate those people. But the problem is, there's a window of period of time before patients display symptoms where they are clearly shedding virus. And by shedding virus, I mean, it's coming out when they breathe. And so that is why this virus is so hard to contain. The other thing that makes this virus very difficult to contain is that, yes, it's very lethal. It's more lethal than influenza. But something like Ebola kills most of the people that it's in. And so the virus doesn't live to infect the next person. So enough people are living with this virus that it's spreading rampantly. So, we get a lot of questions about, and that's okay, you can leave it there. We get a lot of questions about, what about the groceries, or what about, What about, bathroom toilets and things? We'll come to that a little bit later, but largely by and by, we think that surgical masks of both parties, 6 feet apart and outdoors is better. And largely this virus is spread via respiratory droplets. So we'll come to that a little bit later when it comes to what you can do and not do right now. In terms of symptoms, in the initial part, we thought it had to sort of cause a fever and a cough and shortness of breath in everyone. And that's a kind of classic triad of presentation. But we know that some patients could just either have a mild headache or diarrhea. And many of you have probably heard that a lot of young people may have the virus and not even know that they have it. That's called an asymptomatic infection. That's different than something called pre-symptomatic infection, where you test somebody and they're positive for virus and they don't have symptoms, but they might have symptoms in 3 days. There are people who literally have a course of this virus. You can detect virus in them and they may even develop antibodies to the virus, meaning hopefully they would be immune, more on that later, and they would have never had a symptom. But the symptoms that it does cause: lack of smell, lack of taste, that's because the virus gets into those tissues and actually prevents the smell or taste, and it does come back. Headache, and we've had some patients present only with diarrhea. What we see clinically in the hospital, typically there's a pneumonia. For patients who are sick enough to make it to the hospital, we'll see a pneumonia on both sides of the imaging. So it usually impacts both lungs. We see increased markers of inflammation. The white blood cell count, which many of you are familiar with because of your immunosuppression, typically presents on the lower side. We see evidence of heart dysfunction, kidney dysfunction, and this is more in severe cases. And many of you have probably read there's sort of an early phase of this infection and then sort of a worsening that can happen even out to day 10. This is where we start to see cardiac and kidney dysfunction. This is also a disease that seems to cause a clotting of the blood vessels. So many of you who might have been on a blood thinner after your transplant, maybe because you had a clot in a blood vessel for a period of time, this disease seems to cause clotting of both the veins and the arteries, which can lead potentially to stroke. And then we're also seeing some imaging findings on the brain, even absent any clotting of the blood vessels, that are unusual. And so my point is, we're still finding out a lot more about this disease, but we're seeing pretty broad spectrum tissue involvement throughout the body. It's largely a pneumonia for patients who are sick enough to make it to the hospital, but we certainly see other organs involved as well. All right, next slide. So how many cases are we talking across the globe? There are 9.1. Yep, so one question, would it be lower than? We don't know exactly in transplant patients if yours would be extra low compared to if yours already runs low, but in general, if the average population, the white blood cell count, we don't have enough transplant patients infected globally to know whether the white blood cell count would be lower. But many of you have probably had infections before where your white blood cell count went up. When you had infection, this one usually goes down. Total cases across the globe are 9.1 million. This is as of yesterday. And for any of you who subscribe to the New York Times, I would emphasize is a very, very good place for reliable information on the virus. They fact check. They would not be the New York Times if they didn't take their data extremely seriously. They have a free, you can track the virus on the New York Times and plot these graphs any day that you want. And you may want to spend your time doing other things, but I just pulled this off of their website yesterday. In New York Times, you do not have to subscribe to follow the coronavirus coverage from the New York Times. So in any case, 9.1 million cases, and go back one slide, and deaths across the world are on the order of 474,000. This thing called the case fatality rate, which you might have heard of, like, what does that mean, case fatality rate? You can compare different viruses in terms of, okay, like, let's take all the infected people and all the people who died from the virus, and you're simply doing math. Like, what percent of people who get infected die from this virus? And we know that certain people, older, diabetes, obese, there's certain risk factors for doing worse with this virus, but across the board, there's about a 5.2% case fatality rate. Now, we know that probably the number of infections is underestimated, right? We can only know who has the virus if we do enough tests. And so probably the denominator is going to be much bigger than this 9.1 million cases globally. And in enclosed circumstances like the Diamond Princess cruise ship, where you have literally every single person tested on the ship, it's looking like maybe 1.3, 1.4% case fatality rate, but still the math on that is very scary. And we do know that this disease is very surviving with coronavirus is completely dependent on having access to the medical care that you need to survive the virus. And that includes like a ventilator and dialysis and everything else that you need. So, we'll talk more about that in a bit, but the case fatality rate of 5.2% is obviously a very scary figure. Italy was closer to 8-9%. Wuhan, China was closer to 2%. This is globally. Next slide. But in the United States right now, we're at 2.3 million cases and 120,000 deaths. And I'd love to say the United States is this shining pillar. But what you're going to notice on the screen here is that our case fatality rate is about 5.2% right now, too. That means 5.2% of all people who have tested positive for the virus have died. Now, you'll also notice that our curve doesn't look a lot like Wuhan. And basically, for some of us who are kind of watching the curves in Italy and even in New York City sort of go up and then come down like this, you'll notice that the overall cases in the United States have this kind of peak, and then it sort of comes down. And then this is what I call the slow burn. And then now as society is opening up, it's actually on the rise on a whole. Now you can take each individual state and plot something different, but it's certainly not, we're not going down, down, down in the United States. Okay, next slide. This is a plot of counties that was done yesterday. The red is basically counties where cases are actively increasing. And so there's a couple of little spots in Minnesota where cases are increasing presently. Areas that are blue show where cases are decreasing, and that's largely like Massachusetts and New York who got a handle on things. And you can see there's a predominance of red counties where cases are increasing, predominantly clustering in areas of Texas, Florida, and South Carolina. And my colleagues who do what I do on the ground there are actively getting crushed. So the Mayo, Arizona program, they only have 30 beds in their ICU, and they only have one ECMO machine left. And their unit is lined with COVID patients, and bars, gyms, and restaurants are packed with people without masks on presently. For many of you who might have been transplanted in Texas, I just got off the phone with Susie Josephs yesterday, and they just got 5 transfers in of COVID patients. And these, in areas like Detroit and New York City, et cetera, those transplant programs shut down at the time, and VAD as well. They did not have the ICU beds to care for the advanced heart failure population and had to close down until they could reopen. And South Carolina and Florida are experiencing major surges right now. And those doctors who are on the ground right now are feeling it. They're starting to feel overwhelmed. It's like actively happening. Next slide. How are we doing in Minnesota? So this is a look at hospitalizations, because many of the things that you hear in the news is that, okay, when you test more, you find more virus and it makes you look bad. One thing that you kind of can't, mostly hospitalized patients with this virus. So anyone who's hospitalized with pneumonia, I would say from mid-Feb or like early March on, was tested for COVID probably multiple times. And so I think for the hospitalizations, at least, that's the one figure that can't lie in terms of how your state is doing, because the hospitalized patients are getting tested. It doesn't, and you can kind of do some back of the envelope math in terms of how much community spread you probably have based on the number of hospitalizations that are going on. But you can see that our peak was probably towards the end of May, about May 27th. I was in the hospital at that time. We were actively getting transfers in from Hennepin because they had already exceeded their surge plan. Our COVID hospital was full, and we were opening more surge wards over at Health East for COVID patients at that time. So we were feeling the squeeze, and we were wondering whether or not we were going to be able to do bypasses and valves. And we would probably close transplant last, but we were feeling very nervous at this point. But there's been sort of a steady sort of decline. We've leveled off in the last few days, which makes me a little bit nervous. The blue is just regular hospitalized patients, and the green is ICU patients. So those are patients who are predominantly on ventilator support. So there's been a nice decrease. Next slide. And the real key in Minnesota to getting this all under control has been, there's sort of an inflection point with the first arrow, where we went from kind of performing on the order of 400 or 500 tests at most per day into the several thousand. And you can see by the end of May, we had some days where we were performing over 10,000 a day, closer to 15,000 on some days. And then with the protests that recently happened, the access to testing even increased further. So you can't contain an enemy that you can't see. So the timing of this, we were struggling. So I was part of a lot of these phone calls and advising Walls's team early on here that we were going to get nowhere unless we got our testing under control. And so we were kind of 3 weeks behind. And I remember in this early phase, everyone's like, oh, Minnesota's doing so great. Well, you can only look so great based, if you don't test for anyone, you're basically looking really good. But we could tell by the number of hospitalizations and also the number of deaths per COVID that we were under testing. And so once this testing, we were already kind of behind the 8 ball, but the testing has been the key to everything, because between a combination of contact tracing and testing, we've been able to, and protocols within the hospital, been able to get that nice curve down that you're seeing. So next slide. And then the deaths is sort of a different story, but you can see overall that deaths from COVID-19 are going down. And so I'm cautiously optimistic that Minnesotans are continuing to practice good social distancing, wearing masks, and also that the Department of Health, between ramping up testing and contact tracing, is trying to get a handle on this in Minnesota. We're also helped by a lot of things being outdoors presently. Next slide. So what did we do? So probably I think I was at a virtual, or I was at a clinic in Sioux Falls, probably early March. And right about that time, we had our first 30-year-old patient go on to ECMO, which you guys are pretty familiar with that, but that's basically a heart-lung machine with no medical problems. This young guy, and he was a story in the Star Tribune, but basically this guy landed on the unit next to 4E, and everyone kind of looked around and said, okay, not only is it here. So about 3 or 4 days after the first reported case in Minnesota, we started to have ICU patients who were young with no risk factors, incredibly sick. And we were watching New York, we were watching Italy, and we said, okay, we don't have our testing ready. We don't have our PPE. We don't have anything together that we need to. So we basically at that point switched all faculty meeting, everything went to virtual. We separated all team members, like no more in-person meetings, only sign out over the phone. We started to switch to kind of virtual clinics, as many of you kind of experienced. We started to delay testing for a lot of our transplant patients until we could start to get some protocols in place to make people safer. That meant delaying some of your annual testing, kind of moving to AlloMap for some of the rejection screening for some of you who are relatively early on. Trying to keep you guys out of the clinics and hospital space at that particular moment, because we did not have it together. We didn't have testing, we didn't have masking, we didn't have protocols to keep you guys safe. And so we kind of pushed some stuff off. For the new transplant patients, basically some of those, 1 month, 2 month, 3 month appointments that you would have had, we actually did all their testing right in the 2A kind of waiting area. So they would get their right heart and biopsy in labs, and we would do their echo and their visit all without having to drag over to clinic. Again, we switched most things to virtual clinic, and then we accumulated more protective health equipment and developed reuse policies for N95 masks, et cetera, because we didn't have enough. Next slide. Probably the most critical thing that we did as a healthcare system, and I have to give credit to our dean and hospital administration early on, is that any of you who went to Bethesda after your transplanted, any hopefully, or VAD, hopefully never had to go to Bethesda, but it was essentially kind of a vent weaning facility that Fairview owned, or University of Minnesota owned. And they basically found other places for all those patients to go and created a 90 bed, 30 or 40 ICU bed, I think about 60 regular. And basically we decided to isolate all COVID over. And this isn't something that we just invented out of the sun. This was basically modeled after what was working in other places in the country. And, we care for such a complicated group of patients at the University of Minnesota between liver transplant, lung transplant, heart transplant. How can we do our jobs if the place is lined with COVID? How can you guys come and get the care that you need? And how can we get new patients through that process when we have a lot of COVID exposure? And so we created a separate hospital and universal masking. We now, at first, we just didn't have the masks to be able to do it, but I'll tell you, this is working. Surgical mask, so cloth mask, okay, but way better is surgical mask. And so on our floors now, even when patients have turned positive and we've shipped them out or whatever, our staff infections, between staff or between patients and staff with masking and face shields is like negligible. The places where you had so many healthcare workers getting infected in New York City and Massachusetts early is because it had spread through their entire hospitals without them even knowing it yet. And the same was true in Louisiana. You had people putting breathing tubes down with no protection whatsoever, and that was happening in Italy as well. All the sheltering in place that we did in Minnesota helped us get our act together. And we know if we mask, they mask, face shield, we are in hand washing, like we are good. We're, you know, it's not perfect, but it is way, way better. We have policies in place in the emergency room and obviously ramping up the testing. So right now you can't go to the cath lab without getting a test the day before. And we have live time, you know, within hours we have that result. All patients who get admitted to the hospital have a test before they hit the ward. And then any question, we repeat the test, you know, within a certain period of time. All the donors for transplant are getting tested. All the recipients are getting tested within 48 hours. Like we're testing them frequently. We're testing everyone and everything that moves. And part of that is we have to make sure, and then all the workstations in the hospital, nurses are not clustering together and eating together. No, there's none of that. In order to eat as a healthcare provider, I have to sneak back to my office, take off all my stuff, wash my hands, sanitize my whole area, then eat, then put everything back on, and then go back to work. It's complicated, but we're not like hanging out, you know, all clustering together anymore. Okay, next slide. So the COVID-19 hospital, I'm happy to announce, so there are 600 workers who have been through that hospital in the last several months. We've had 2 coronavirus seroconversions, which obviously we want that to be 0. And that's very similar to some data that just came out of a Chinese experience where they had very, very high risk, team of doctors and nurses and respiratory therapists who were doing aerosolizing procedures, meaning they were putting patients on ventilators and down their respiratory tract, and they had 0. This thing called donning and doffing, which is basically putting on all the protective gear and taking it off. If it's done well, the risk of infection to healthcare workers is extremely low. Our survival at our Bethesda COVID hospital for ventilated patients, 75% survival. They're reporting New York City 12% survival, which really goes to show you. So maybe we were a little more selective and maybe an 85-year-old with chronic conditions didn't go onto the ventilator based on Wuhan, Seattle, early experience in New York. But what we're discovering is if you leave people, these people don't go on the ventilator for 3 days like you did when you had your transplant. They go onto the ventilator for weeks. If you go onto the ventilator for weeks and you get the dialysis that you need and you get all the other things, those patients are not dying. Now, granted, we also have some clinical trials and some other things that we're trying, but even absent like a definitive treatment for this thing. And so I think honestly what was happening in New York City is they looked at the Wuhan data of ventilated patients doing very poorly, and they looked at Seattle with, you know, a 90% chance of dying if you were on a ventilator. And in New York City, they honestly didn't have, I know there wasn't a ventilator shortage that was reported, but what happened was from my colleagues on the ground there, they didn't have antibiotics, they didn't have sedative medications, and they didn't have enough dialysis units. And so if somebody was on a ventilator for a week and they were 75 years old, and if they started to need dialysis and they didn't have the dialysis circuit, they called the family and said, there's nothing we can do, and they moved on to the next patient. And so I think those patients might have lived otherwise, and that's really horrendous to say, but I just want to emphasize to you guys how critical it is that the ventilator and the dialysis machine and the critical care team, it's so many components. It's not just the ventilator, it's the respiratory therapist, it's the ICU team, it's the dialysis, it's all of it. If those care is provided, patients did better. Now, this doesn't mean run out to Target and like kiss all your grandchildren, but it is a little bit towards feeling a bit optimistic. Okay, and then obviously we've been doing a ton of research in this area. So one thing that I'll just say, so not only is this a scary time for everyone here, but can you guys imagine walking yourself back in time towards sitting in the hospital and hearing about a VAD, hearing about a transplant, maybe you need a temporary support device, maybe you're starting to get worse, your kidneys aren't doing well, the team's coming in every day to tell you that you might need a transplant, and you're completely and utterly alone. It is heartbreaking for those patients, but it's also very, very taxing on the doctors as well. We've had some patients recently not doing well whose teenage children couldn't come to see them. It is like taking our hearts and cutting them out. It is really, really challenging. Visitors are not allowed in the hospital at the present time, and I think that could be changing for the better shortly. But you guys who come around and visit with the patients and kind of say, look, I'm doing pretty well. I was in your shoes once. They're not getting that, and they're also not with their families. And also the only time that I'm allowed to call in family is if it is a like withdrawal of care, or basically a super end of life goals discussion. And I've even been kind of reamed out if somebody was still living the next day after I called the family. And I was like, well, I'm not, you know, it's not looking good. So I'm going to just call the teenage kids in. But I've gotten a talking to because the patient was still there the next day. I was like, well, okay. So it's been really, really challenging. And I'm hoping Hennepin County has started to allow 1 or 2 visitors with masks per day. And part of the issue early on is that we just didn't have the protective health equipment to give those. We needed to protect our janitors, our, everyone in the hospital needs to be protected right now. And we just didn't have enough masks to give to family members as well. And I think the more we understand about the infection, I think that will hopefully be changing. A lot of our clinical trials, many of you on the pre-transplant side, we have a bunch of really cool clinical trials that we were starting up. That's all been delayed and stalled at the moment, just because performing clinical research in heart failure and in VAD and transplant is all very, very challenged by many of you, I'm sure, were clinical trial participants at some point. Imagine trying to come into clinic to do all this extra testing for the clinical trial. It's just not feasible at the moment. And the other thing that we're seeing is that patients really didn't seek medical care. And I'd say for the first 4 weeks of the pandemic, that was appropriate, but we are seeing some impact from that. Next slide. This was a analysis that we did and submitted to Heart Failure Society. The red line is basically 2019 and the blue line is 2020. And this looks at discharges across the hospital system by day. But essentially, you can see that heart failure hospitalizations across our system were down significantly. And that's not because there's suddenly less heart failure in Minnesota. Next slide down. We know out of New York and New Jersey, this is like a plot of sort of excess deaths that were seen between March 15th to May 2nd. In New York and New Jersey, this was extra deaths that were seen during that time period, and they could attribute, I think, 68% of them to COVID-19. But by autopsy studies and by medical examiner studies, it shows that there was an excess of 15% of those extra deaths that happened at that time that were due to cardiovascular disease. So these were patients who were likely staying out of the hospital, kind of riding out their heart attack at home or worsening heart failure, who just died at home, not seeking medical care. Next slide. So I just kind of want to emphasize to you guys that at this point at the University of Minnesota Hospital, obviously, I know it's scary to get near any sort of, you've been kind of camped out at home trying to wait to see what was going to happen. But essentially labs need to be drawn. We do need to do some surveillance testing to make sure you're safe. And if something comes up, you're not feeling well, more short of breath, you need to get it figured out. We have so much in place at this point to keep you safe during your medical care experience with COVID other places, with the testing and the masking, that I would encourage you to make sure that we stay, for the most part, on schedule. You guys are going to need your flu shot. Some of this stuff needs to be taken care of. And we're doing a really good job. If you need hospitalization, I feel like it's much safer than it was at the beginning of March. Let's put it that way.
If I might add one thing for you there, Color,
Yep.
and we've got a couple questions. I think it might be a good point to
Yep.
throw those in. I know I was personally encouraged, and I was actually encouraged to encourage others to just pick up the phone and call your care coordinator if you think you have something going on. Don't forget they're there, and they're waiting for your call, literally. So to the point of current care, all these kinds of things. Remember, they're there for your first line of defense often as well. One question, couple questions, if I might, while we were still talking about the hospitalization, and there was a question about, okay, and this is a little hypothetical, let's hope this doesn't happen, but if
Yep.
one of us were to get infected, would we go to Bethesda or would we come to the U?
It's a good question. We have had transplant patients go to Bethesda with us consulting, and it depends on how sick. So we have sort of made the decision that within something like the first year after the heart transplant, the immunosuppression is nuanced enough that we would probably house that patient at the main university campus with our transplant infectious disease colleagues, et cetera. Or let's just say somebody is 5 years into transplant and has very abnormal heart function or other issues that have been complex with their heart transplant management, we might favor having them at the university. If somebody has what I call stone cold normal graft function, meaning that transplanted heart bounds away perfectly, not a lot of complicated immunosuppression questions going on with this person, has been doing quite well, and we don't think is going to need like a heart lung machine like an ECMO circuit. Those patients have been sent to Bethesda with us consulting as a team every day, and that has worked. And so it really, as of right now, we're still trying to keep the COVID outside of the main university hospital. That is currently the policy.
Okay, another question. Dwight Hinkle just popped up. Dwight, I'm actually going to defer that question for you to contact your care coordinator. Uh,
Hi, Dwight.
this is being recorded, and I don't know if you want your actual, if we want to get into things, but his question is simply, he's got a checkup coming up. Could he have it done in Bismarck as opposed to coming down here, considering everything? And, that's probably a further little thing there. I don't know if you want to go into that now. But good
Yeah.
question, and Dwight will be sure to help you out with that. Um, let's see. Another question that was earlier I meant to ask that had come in, and that is when you were talking about the trend data, specifically, what about the weather? What about the weather?
Weather is interesting. So, there's some models showing that UV light might inactivate virus, and everyone gets really excited about that. But if you look at the counties that are surging right now, so India is hot, 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 surging right now, and pregnant women being turned away from hospitals. Houston, Houston, Dallas, Florida, Arizona, all very hot places are surging at the moment. And so I would love to sort of tell you that there's some sort of protective effect of heat or something, and that was everyone's hope, but that is really not turning out to be true. Now, in terms of the weather, Minnesota, I think, is helped at the moment because any congregation that's sort of happening of people at this moment, because everyone's just dying to see their family and friends, is oftentimes happening outdoors right now in Minnesota. So I think that is helping. We know that indoor, the likelihood of transmission is much, much higher than outdoor. So I would like to say that the weather in Minnesota is helping us. And we're also seeing with the protests recently, those were all outdoors. Now we're probably about another week away from starting to see a major uptick. But with an incubation period, which is meaning time from exposure to start to have symptoms, it's getting a little less worrisome each day that we're not starting to see a spike up which is again further evidence that outdoor, and a lot of those protesters were masked as well, but outdoors is helpful. But I hope I'm answering that. So whether there's a lot of problem at the equator and around in a lot of the Central American countries. So we'll get to take out food. We'll put that on the notes
Yeah,
later.
there's actually several of these questions we have coming up in an upcoming slide. So we can.
Yep. Okay. So come back up to the transplant patient. So I have some sobering news for you guys on the transplant front. So we don't have a lot of information yet specifically about heart transplant patients. So the first article that came out was out of Wuhan and basically said, oh, our transplant patients did great. But guess what? 0 of their transplant patients got coronavirus. Are we Wuhan, guys? No. So I actually wrote an editorial to the Journal of Heart Lung Transplant. I calculated the number of living heart transplant patients in the United States right now by decade of how old they are now. And we have a lot of vulnerable heart transplant patients out there. So the first start of publications started to come out of New York City and also out of Spain with heart transplants specifically. And we're talking studies of about 28 people or 30 people or 45 at most. So we're talking about a small clustering. Case fatality rate among the transplant with average age being about 55. We're not talking about 80-year-old transplant patients or 70-year-old. case fatality rate was between 23 to 29%. Meaning if you got the virus, about 25% chance you would die from that. Okay, so like I'm not here to totally freak you guys out. I'm just stating facts. Now, could this be that in another 6 months, we actually find out that a whole bunch more transplant patients got it and did much better than this? Absolutely. And also as we start to get better cocktails of treatment, and as we start to realize that staying on the ventilator longer is what we should do, et cetera, and you guys are in a really good position. Minnesota has enough ICU beds right now. We're in a good spot, but that's a sobering number. And it's not like anything's different about the virus now than 3 months ago before we opened up. So this is not exactly the time to let our guard down. Next slide. This is not a science slide that I'm meant here to overwhelm you, but I just wanted to sort of emphasize how much the globe is working on this right now. We have several different ways. We have a couple of different antivirals that we're working on. We have antibodies that we've developed to the virus itself. We're working on trying to modulate the immune response to the virus. And so there's many different ways, in addition to vaccine development, which is what everyone really wants. There's many different ways and different cocktails of this that are trials. And on some level, the fact that so many infections are occurring and academic centers are working on this and collaborating, science is happening in a really fast way. Almost to a point where, we're having to sort of police ourselves a little bit because some misinformation has made its way into high medical journals as well. And so everyone in the community is wanting to support rigorous data at this point, but we are coming at this virus from about 15 different ways right now. Next slide. Okay, so transplant and VAD patients, you're all wondering, can I go back to work? Should I go to a restaurant? Can I use a public restroom? What about if I want to get my hair cut? Do you guys see this? This is not good. What if I want to go brown? Yeah. What if I want to go to the gym? I really want to go to church. I miss my community. Can I go to the grocery store? And like the big one, right? Like you got this transplant, you got this VAD because you want to spend time with your family. What about those grandchildren? What about your own children? What about family gatherings? Like how do we possibly navigate this? And then everyone, Fauci is on some level optimistic. I would say vaccine. So there's two ways that the country is going to get past this. One is if we reach 60 to 70% infection rate across the entire country. But I have a slide at the end of this that shows the math and the pathway of death. If we choose that strategy to just say, screw it, let's just infect everyone so we can get back to life as normal, the death count from that is going to be astronomical. The alternative strategy is we get a vaccine that's effective. The leading vaccine experts in the globe from the time of February 2020 at the absolute earliest, which would be faster than anything that has ever been done in the vaccine world before, would have been 18 months from Feb 2020. Then keep in mind, we have to manufacture it. They're already readying lots of different manufacturing capacity throughout the, we're gearing up to start to make this, but then we also have to implement getting it to everyone who needs it. So, you're sitting there thinking, well, like, God, Dr. Cogswell, I can't stay in my house until there's a vaccine. You're talking about 2+ years. Yes, I am. And as Glenn Kelly was sort of telling me yesterday, we kind of came at this initially with a hammer, right? We sort of said, okay, let's just everyone sit in place until we figure out. And that allowed us some time. And then we are discovering more things about how the virus transmits and how to mitigate risk. The zero risk thing to do is to not get together with anyone, to not go to the grocery store. But we also have a reality check here too. Some of you need a paycheck. Some of you need, to see those grandkids. And some of you might be at a phase of your after your heart transplant with some other stuff going on where maybe you may not be here in 2 years and you want to see those grandkids. And I completely understand that. I myself have a father who had a heart transplant and he lives in New Hampshire, and I'm grappling with what is he not supposed to see my oldest? We just saw him a couple months before this all happened. What am I not supposed to see him till he goes from 11 to 13 and a half? That's a huge part of his life. So I'm struggling with this too. So go to the next slide. So what I can sort of tell you is we do know some things. And then you guys are ultimately going to have to make a decision that feels right for you. And I also have some literature that I'm going to give to Glenn at the end of this about how you can sort of make this decision. One thing that we for sure know is that indoor contact is much higher risk than outdoors. This is one thing that we know. We know that masking, not cloth, surgical masks of all parties involved and some distance reduces risk of infection considerably. Now, that might not seem like the kind of family gathering you want to have with everyone with masks out in the front yard, but it's better than nothing. The length of exposure matters. And so when you're thinking about, wow, maybe we want to have dinner with that couple at that nice little cafe indoors, if you're sitting across from somebody for over an hour, or maybe getting your nails done, that the amount of time that you are stationary across from somebody matters. So like if you're hopping into the gas station, pump the gas, wash your hands afterwards with your mask on and hop in your car, that's like a, even if there was virus floating out in the air somewhere, like you're there for a hot second. Sitting across from somebody, say for example, getting your nails done, you might have to ask yourself, how much do I really need to get my nails done to be within that number of, even if you're both wearing masks, that's a lot of hour-long contact with somebody. So the length of exposure matters. And I'll also just tell you that as society opens up, the likelihood of family members getting exposure all over the place is going up considerably. On some level, it almost would have been better to gather when we'd all been sheltering for 2 months. Next slide.
Well, I'm moving the slide forward. One quick idea that I know some folks, even on this call, have used. If you got to have a haircut or if you just have to get your nails done, the precautions Dr. Cogswell mentioned, keep those in mind, but see if you can't get them to do it for you outside. I know a couple of people that have had hairstylists come by and do it on their back deck for them.
Yep.
So helps that even more.
Absolutely. And I mean, I fear for us, honestly, in the winter, because now we can get really creative about outdoor stuff. But the winter, I don't know if you guys watch Game of Thrones, winter is coming. Okay, so what do we know? Gyms, bars, and churches have all been sites of repeated, documented, what we call super spreading events. There was just a bar down south over Memorial Day in Arizona. It was a double stacked bar, packed, not one mask on. The number of infections after that is like logarithmic scale. So churches, you guys all heard about the group that all stood far apart from one another, and there happened to be one asymptomatic person there singing. We think projects the virus, and then what they call the attack rate, like the number of persons within that group, and everyone hand sanitized. Like the number of people who got, and then of course people who are church going, like oftentimes have chronic conditions, et cetera, maybe a little bit older demographic. Those are events that are not, now if the church wants to hold something outside and 6 feet apart with a mask on, okay, I'm feeling better about that. But the yellow or blue, yep, the yellow or blue, those are surgical masks, yep, and they're pretty available now. N95 is, N95s are the ones that 3M makes, and it'll say specifically N95 on it. N95s, we're not even using those in the hospital unless we are in the COVID hospital itself or doing procedures where patients are likely to spew a lot of virus, like putting a breathing tube down or suctioning. So we are pretty sure that just the plain yellow or blue masks that you can buy, even at Walgreens now, or you can get them online, they're the ones that we use in the hospital. And that's what all of our healthcare workers are. And I'll tell you, so we just had a salon incident where the CDC investigated. There was a woman who went and cut hair in an indoor salon, and she was infected for 3 days before they realized she had it. And they contact traced 140 clients who went through that she wore a surgical mask, she was infected, and not one other person got infected. Now, this doesn't mean like, oh my God, yay, like let's go all get our hair cut. But that does give me hope that protected. I mean, a lot of kind of wearing the mask in parties, both masks, really reduces not only transmission of somebody who's pre-symptomatic and could be spreading virus, but how effective that was. So I think, and that was, a salon that was trying to do some distancing between chairs and some other things, but that person exposed a lot of people, and they contact traced everyone, and not one person converted or tested positive. So I think that Cloth masks do help some. We think that, but the evidence is much stronger for surgical masks. So if you have to go into somewhere, a cloth mask is favorable over no mask. But for sure, the surgical masks filter more virus particles. And this is just the evidence on this is overwhelmingly positive, meaning it works. Okay, you
One
hear
thing on your slide,
yeah.
if I could help you, a couple of specifics I know I've heard, when you're citing some of the things, what we know, gyms and so. So let's bring it to home here for a second. We know we've got Lifetime Fitness here. They do great things. Really big gym, really big. It's indoor tennis. It's indoor, everything, unfortunately, for the most part. Still pretty risky, not risky, even though it's a bigger space, you got a lot of people working out. What's your point of view?
Mine.
Yeah, that's what we're asking.
Yeah, I'm honestly for you guys, I'm worried about gyms still. I mean, I think if we have some, like, let's say it's a month or two from now and Lifetime comes up with some data showing that with 50% occupancy, wiping down all the equipment and masks on all the employees and that they are not having any transmission there, I'll feel more confident sending you guys in. I need a little more time and a little more data not showing gym spread for me to feel that that's a good idea.
Gotcha. Back on the masks, how often can you reuse a surgical mask, do you think?
Yeah, I think like if it sort of depends on whether you think you're going into and also like the right way to use a mask, right? So I think when you're going into a clinic setting, say you've got to go get your labs drawn or something, and you've got that mask on. A clinic setting is an area where I think there could be COVID floating in the air, and so when you get back to the car, that mask for me should go into a paper bag and you should immediately hand sanitize after you touch it because you don't want to touch the mask, which could be laced with COVID on the outside. And I'm not saying that it is, but you have to mentally prepare, like think that it is. You gotta hand sanitize or wash your hands really well. I wouldn't go, if you leave that mask in a bag for a couple of days, probably any virus that might be on it might be good for another wear. But after that, I would probably toss it.
Great. What else do we know?
Oh, cruises. Oh my God. So they just did a study and why anyone participated in the study is beyond me. Okay. So the answer to cruises right now, guys, that's a hard no, no, no. So congregate settings, prisons, nursing homes, I mean, honestly, dormitories, migrant workers all clustered together. This is a place where virus spreads rampantly, and cruise ships, unfortunately, are one of these. They just did a study of a cruise ship where every single person who set a foot on the cruise ship was tested beforehand. They did temperature checks. They had tons of protective health equipment on board. They serially tested the people on board, and one passenger got a fever and they shut the whole thing down. Everyone went into their cabins. Every staff member put on N95s. They shut it down. Delivery to the rooms, something like 40% of the ship got the virus. So that's a hard no. It's a hard no. For now, and how cruises are going to stay in business, I don't know. Okay, the flushing the toilet, aerosoling the virus. We know that basically virus does get secreted in stool. It's probably not live virus that's sitting on the stool, that's on the toilet bowl. We do know that the flushing of the toilet can send that virus into the air. Whether or not that's actually going to cause infection in a public bathroom is not really known. But it does make you feel like you should wear a mask if you have to go into a public restroom and wash your hands very, very well. And obviously don't touch the door handle on your way out, and then mask off, hand hygiene. But in general, if you could maybe go to the bathroom before you have to go to the store, that would be better. Okay, next slide. So in terms of just the number of possible scenarios that could come to us, and, infectious disease colleagues across the country are getting asked, can I have a family reunion? Can I get together with the grandchildren? What about returning to work? You have to sort of learn to kind of frame the question. Should I send my kids to camp now, or should I wait until August? Should I not send my kids to camp? Should we have the family reunion? Should we not have the family reunion? You have to think about how you can mitigate the risk, then evaluate the risk, think about the benefits, and then make a decision that's right for you and your family. So I'm going to give an example here. So basically, if you sort of decide as a family, you know what, we're not going to wait for a vaccine to sort of get together. We just can't wait that long. We're going to have to get together. If you're asking yourself, should we have the grandkids over to the lawn next week or should we wait 3 weeks from now? If you've already made the decision that you're not going to wait until a vaccine is available, there's really no difference between this week and 3 weeks from now, right? So the answer to that would be like, why wait for 3 weeks? Because we already decided as a family we're not going to wait for a vaccine. So let's have the kids over to the front yard where wear masks, we'll be 6 feet apart, and we're not going to share food. Doesn't sound like a lot of fun, does it? And I work at okay, we have a work question there. Okay, so next. So from a work perspective, for those of you who are at jobs that can be done remotely, places, Silicon Valley, like leading organizations here are still having their employees work from home. The whole idea of reopening society isn't everyone going to pretend like the virus never existed. It's going back in a modified way, right? It's masking, it's plexiglass, it's keeping people with chronic conditions home if they can. I understand that not all work environments are going to support that. And then it's like, what about the spouse? Like, can that person return to work? These are, you guys have to decide as a family, like if you need to work, it's how do you keep yourselves safe? And most work environments, in Minnesota are encouraging social distancing of some capacity, less office, clustering, not shared food spaces, masking of all employees. Like this should become kind of standard at this point. And so I think if masks are worn when you go back to work, or the crowds are sort of taken care of, but if you have a job that completely translates to working from home and your company supports that, why would you not do that?
Well, let me ask the question because I know of at least two off the top of my head. And Jen, thank you for the question online. What if you work in healthcare and you're a transplant recipient?
Yeah, I mean, I think I'm getting more encouraged. The Bethesda information for me about the healthcare workers, like that is very encouraging to me that we can actually keep. And there's actually some evidence now that hospital transmission between healthcare providers or between patients and healthcare providers is almost lower on COVID wards now because everyone is fully geared up for it. And so I'm less nervous about transplant patients returning to a healthcare environment now than I would have been 2 months ago, based on some of the evidence that we have that healthcare workers can be kept safe with, with the right precautions, right? So like maybe that healthcare worker shouldn't work on a COVID ward, but maybe that healthcare worker would be allowed to return to some, even the clinic coordinator, like a lot of our coordinators are working from home now, and even someone who are in clinic, people aren't clustered together. So I would say for the healthcare worker, transplant patients, if some accommodations could be made towards some work from home, and also if they do return, could they make sure that they have the right protective health equipment? And that would essentially be face shield and surgical mask every day.
Got it. Uh, a question that is related to what's on the screen, a couple practical versions of this. What about, you've got teenage kids,
Yeah.
and yeah, this is the tough one. This might be one of the more difficult questions. And they want to obviously be with their buddies, and how to manage a daily life.
Yeah.
I mean, your boys are a great example. How does one potentially do that?
So like in terms of we are feeling as of right now, so I know many of you saw that the post-inflammatory syndrome in children is a really, really scary thing that can happen in kids. But by and large, like for young school-age children, we're not seeing a ton of sort of spread or infection of adults. And so this does give some optimism for young school. High school and older, that population actually is having some evidence of severe disease from the infection, and this is going to definitely impact universities. And I think the idea that kids are going to sort of go back to some university setting and somehow not be at a frat party or socialize is delusional thinking. And then think about this, they're going to all be at their universities and then they're going to fly back to their home states. Already just today announced Connecticut, New Jersey, in New York are requiring any place with a higher infection rate, somebody returning home has to quarantine for 2 weeks. So there's a lot of complexities. Okay, so what was the one job question? It was retail or, the teenage kids. early on in the pandemic, there was like this concept of isolation bubbles, which is finding maybe two other families who a very hard conversation was had with them about what they were and weren't doing. Were they allowing cleaners in? Were they seeing anyone else? What were the work environments for and then actually what's called kind of merging the isolation bubbles, so that everyone's of those three families agrees that they're not having contact with the outside world. And a period of time has gone by, and maybe even now with some additional layers of could everyone get tested, or you have like a 2-week stretch of time where everyone's on total lockdown, and then you have a group that you actually interact with on a regular basis. So, but now that things are opening up, this is going to be increasingly complicated. I mean, transplant patients, I imagine, are going to have to send their kids to school in the fall if they open. And I can't even say that I know what that looks like.
All right. But I know we're at the top of the hour. If we can just kind of keep going through some of the slides here.
Yeah. And then, and I would just say, unfortunately, everyone wants all this modeling of what's going to happen in the United States. What we are finding is our curves don't look like any other place, right? The curves in the United States, like people value their personal freedom and and we also don't have the most organized healthcare infrastructure. And we were unprepared for this. And so our curves are going to unfortunately look very different than the rest of the globe. I do personally think, and I'm probably going to draft another letter to Walls very soon here, with the way that it's going in Minnesota right now and taking advantage of the summer, I think that there is a real chance, and I told Glenn this yesterday, if we double down as Minnesotans right now, meaning I'm not talking about like shutting down everything all over again. I'm talking about contact tracing every last, all the nursing homes, all the congregate settings. Like if we really got a hold of the virus in Minnesota, like way down, way, way, way down, we might be able to have a completely open society again. Every bar, every restaurant, every school, open. And then we would just cluster when cases came up. That's a real possibility. We would have to like literally quarantine anyone who came into the state. But this is like the New Zealand model. Like New Zealand has gone back to business as usual because they have no cases right now. And so when you have no cases, you actually can just live normally. You don't have to live like this. And that includes family gatherings, that includes everything. And so I think we have an opportunity, and we might have a better, rosier story than some of the places in the South. I personally think that 18 months is a very optimistic time for vaccine development. I think you guys have to mentally get to a space that we might be dealing with COVID. Hold your breath for the next 2 to 3 years.
Tough stuff.
If I am wrong, and if we have a vaccine in February, I am going to be the biggest happy dancer you have ever seen in your life, and I will be gladly super wrong. And I will be so happy, but I just need you guys to get into like a mental mind game. And I do think that there will probably be, if we don't get a hold of the virus in Minnesota, I think there will be, kind of openings with partial shutdowns, like openings with kind of partial shutdowns as we reach a certain ICU capacity in the fall, where maybe schools get shut down again and then they sort of reopen, or like maybe schools have half the kids one week and half the other. It's not going to look normal for a while here. I don't want to do the scary math, but in any case, like, everyone's just like, like, let's all just like let everyone get infected. This is, if the US population is 328 million, in order to get to what's called herd immunity, which is enough people getting infected or vaccinated that there's enough immunity in the population where the virus won't take hold.
If I could interject there, that's an important note that I think it's one of the more misunderstood points is the concept of herd immunity. And you may want to actually define what herd immunity means, because I think people just think they're going to be immune all of a sudden with herd immunity.
Yep. And so basically it's a threshold of population that has immunity to a virus. So let's say like measles, for example. If enough of the population gets vaccinated and has adequate immune response to measles, even if little outbreaks occur, they can't possibly take hold and spread because enough people around that person are immune. So outbreaks don't spread like wildfire because they hit blocks of people who are immune to it and it shuts it down.
Yeah.
So
in order to get there, Well, the kind of numbers you're citing
Yeah,
here,
60 to
probably.
70, 60 to 70% of the population will need to be immunized or infected. Now, okay, that's a whole other can of worms. Like, we're not totally sure that getting this virus, the antibodies that we're seeing that are forms of this virus, how long they're going to last and whether or not they're going to neutralize virus. And so, like, that's a whole other can of worms. But we're just in the early phases of understanding what past exposure to this virus means in terms of future events. And our hope is that it's something like measles, where you get it once and like you just need a booster vaccine later and you're good for life. But it could be that this virus mutates, and it could be that our immunity only lasts 3 months, and that coronavirus is with us for the rest of our lives. Aren't you glad you guys tuned in today? But anyway, if we let it burn through the population, and that 5% case fatality rate, I mean, that's without our ICU systems being overwhelmed. It could be considerably higher than that if it burns through everyone. If every society in the United States just says, to hell with it, we're just opening everything, I want my personal liberties right now, the case fatality rate will be much, much higher than 5%, because all the ICUs will be overwhelmed and the death will be pretty unbelievable.
Okay, great.
Okay, that's a nice happy talk. Okay, but you're going to be
No,
fine. We're here to help.
there's a few questions that were here if you can
Yeah,
hang for a couple of
yep,
minutes. And great questions about mask. And obviously,
yep.
mask is distancing followed, I would assume, by mask is probably our number two defense right after distance.
And honestly, I'm saying mask, like distancing is important, but I just was on a UCSF webinar a few days ago with experts, and they're just like, we are probably getting to a place where like mask is like the most important thing. But yes, definitely not heading into crowds in indoor environments, and definitely masking.
So the point of mask usage first is, there's the notion of UV light as a disinfectant.
Yeah.
That's something someone could rely on to reuse masks, to disinfect a mask with UV.
Yeah, so we have, and then I'm gonna, we were looking into this. I'll probably have to post some online, resources after this. Surgical masks, N95s are like gold right now to us. So we have a lot of research that's been done into how to, and specifically N95, 95 refers to 95% of particles are blocked by the mask, which clear out more virus than a surgical mask. But as I've already said, surgical mask is pretty darn effective. But the N95s, there's just aren't, they can't produce them fast enough for the whole globe. And so we've done right now up on our wards, if I have an N95 for the day that I need to use, it goes back into a paper bag and I put my name on it. And then it appears the next day in a clean, and basically there's an overnight staff that's doing a combination of UV light and some other treatment of the N95 masks that we can reuse up to 5 times. But that's not something you're going to translate to at home. And so I think for you guys, like if I was going to just use a quick mask at the gas station to pump gas and then, head into a grocery store, and I didn't literally get within 10 feet of anyone that entire time and it was super empty, I might be tempted to reuse that mask. If I went into a clinic setting where I think the likelihood of COVID is higher, I would probably put that mask into the garbage and then hand sanitize after.
Good suggestions. What about, a lot of the N95 masks you can see, they have the valve. I know I've seen a study on it, but do you have any point of view on the one with the valve, without the valve?
The valved ones protect you, but not others around you. So the valve one makes it easier to breathe. So that concept of like you can breathe in much easier with the valve, but you actually, it filters what comes in, but it doesn't filter what goes out. And so on some level, wearing, like, we want to protect you guys, and that's maybe an easier mask to wear. I think, for you guys, honestly, at this point, and this is where I might be going off the COVID Command Center recommendations. If you guys were going to get onto a plane, which I really don't want you to, but if you absolutely had to, this would be like full face shield, N95, glove, don't touch anything type of deal. So, I mean, that would be a setting where I think you guys would need an N95. I wouldn't say for just heading into the pharmacy to grab something or heading into the grocery store to grab something that you guys need to N95.
Good points. Back on the practical side of things,
Yeah.
you may want to just touch base on the whole restaurant notion, indoor restaurant, even 50% capacity restaurant, and then finally takeout.
Yep. Takeout. I wasn't doing takeout for a while just because I thought we were a little concerned. We know that virus is emitted in stool. And I just hate to say this, but restaurant workers, like, this whole concept of fecal oral. So, uh, hepatitis A, for example, is spread via fecal oral pathway, meaning virus gets secreted in the stool, it gets onto hands, it gets into food, and then you ingest it. What we think is that as of right now, we are thinking that the main mode of transmission is actually respiratory droplet and not necessarily consumption of virus in food. Plus, you have all your stomach acid. So, as of right now, um, the concept on takeout food is that that's probably a lower risk behavior.
Okay.
Thank God.
Yeah.
Now, restaurants, so indoor, I'm worried. I mean, this is honestly the time, like if you want to capitalize and enjoy on summer, and maybe you think about planning something in the South for the winter so we all don't go totally nuts. But I'd say like this is the time if there's a good socially responsible restaurant that that can do outdoors 6 feet apart and go out and enjoy that, this would be honestly in my mind the time to do that. In the fall, I don't really want you guys indoor at restaurants. Restaurants are having outbreaks themselves. Lots of restaurants are among their workers, they're just clustered together. So there are a lot of these restaurants that opened in the South and were doing indoor have shut down because of their infection rates to try to figure out what they're going to do next. But outdoor only feels safer than indoor to me right now.
Got it.
And I'll just tell you guys a personal story. So, like, I feel like so my parents are in New Hampshire. I've had my dad on lockdown since about March 2nd. Sorry, Dad. And he's 20 years post transplant and obviously doing very, very well. But I also want him to see the kids, and so we are doing basically. I'm going to be out of the hospital for over a week and a half. My kids are completely. We're not allowing anyone like in my house. We had cleaners last week with a mask, but basically it's like a full lockdown thing. And I'm getting testing for my entire family at day 7 of full lockdown. And I'm gonna once my dad and my mom are driving here. They're gonna stay overnight in one hotel and like wipe everything down. And they're basically gonna get here in a COVID bubble. And I have them not using public restrooms. Like I'm not joking. I'm like bringing them here in a COVID bubble. And then we have a big lockdown stretch with my kids ahead of time, plus negative nasal swabs. I might even do it twice, a couple days apart. And we're going to come together. And that might be the last time that I see them before next summer. Because I don't see any way how the winter, I'm getting my brain around how it's going to look in the winter. And I'll, if we do another one of these, I can give you posted on how we're doing this. But we are basically, and it's complex too, because my sister and her teenage kids, they're completely unwilling to do this. Like they're all in distance sports in New Hampshire and stuff. Like they're not going to stop to do that to get to have a real family gathering. But technically the longer that each party locks down ahead of time, you can bring groups of people together. And even now that testing is enhanced, say you had 2 weeks of complete lockdown, negative nasal swabs on everyone, come together. Is it zero risk? No. The safest thing to do would be to not get together or maybe be in the front yard like 6 feet apart or whatever. But I personally feel like I don't know if I'm going to survive that long without seeing my parents and them seeing their grandkids. And so we're coming up with some kind of plan that mitigates that risk and taking it. And is that the right thing to do? I'll report back. But
Thank you. That really, I think, brings the home. I think the tenor of many questions I've been hearing from folks and seeing here online, in fact, is what if I want to what if we want to visit? I won't even ask you to comment on an airplane. I think we
no.
all know that one easy enough. But just distance travel and just interacting with family and what are the real safe ways I think to do that medically. Uh, a couple other points that I want to make sure we hit on. And by the way, I'll take a moment here to say, guys, yes, this recording will be posted online. Dr. Cogswell has some recommended resources for us that will be posted with this in the days to come. I'll have this on our website, which I think all of you know, secondchanceforlife.org, and it'll be available there. And we'll have these resource links available there as well, just here in the next couple of days. Back to a couple of quick questions, if I could.
Yep.
One, okay, rapid testing. Notion of like 24-hour turnaround. What is the current kind of got what are they? What's their benchmark right now for testing as far as turnarounds?
So right now in the hospital, we get a test back in 3 hours, which is amazing. I know that communities, so in the beginning of this whole thing, you might go to the public health and you get it a week later. Well, that's helpful. Like now you've exposed your whole family, right? That's just not real time. So it really depends. And so there's a lot of testing sites available. If you go to the Minnesota Department of Health, you can actually see all the testing sites that are open close to you if you and your family want to get tested, at least in the Twin Cities. Just if you're lived in the neighborhoods where protests were happening, et cetera, you can just like get a test without even having any symptoms, which I think in theory, the Department of Health wants the testing to be even more widespread. They want more people showing up for testing. I think, honestly, Dan, in the next 3 to 4 months, it could be to a point where you literally like have a home kit. And there's some mathematical modeling right now showing that if every business place in the United States had testing of every single employee and every single child before school, like it would be billions of dollars of infrastructure, but the amount of savings, like to be able to completely open the economy back up like that and keep those people out of work, it would actually be economically favorable to do so. So there is a lot of work going into rapid testing. Probably in the community, the times have been shortening and shortening. Even in the last 2 months, we went from it took 7 days to get the result down to like about 24 hours. And so I do think real time, just like when you go to Target, get the swab within 5 minutes, if you have flu or not, like we're going to get there like within the next couple of months, I think.
That's great. That's great. Real quick, I want to jump back to something because I think I want to let you. I don't want to lead you on this one. Air travel.
I would, definitely the airlines are making better efforts right now towards like enforcing everyone being masked, et cetera. But I just think it's a congregate clustering. And if you look at the model of aerosolized when people cough on an airplane, I would rather you guys avoid it. Can I control everything that you guys do? And obviously, if someone's dying in California and you've got to get there, I totally understand. If you have to get on a plane, I would N95 and face shield, and glove up, and I would not touch any of it the entire time. And I don't really want you doing it, but if you absolutely have to go somewhere, now if it's just because you like want to go like be on the sandy beach, I would think twice.
Okay. Good advice. Thank you. Back to one of our routine medical questions. What about dental cleanings? What about the dentist?
About the dentist, so dentists are doing better now. So, the dentist, really the worry is the dentist going to infect you because the dentist is in everyone's mouths all day long, right? So the likelihood that the dentist may be carrying some, or the dental hygienist might be carrying some infection, but they are completely geared up at this point. They have face shields, they have N95s on at all times, and they're pretty much masking up before everything that they do in order to open. And so I do feel that if there needs to be and that it could even be in the point in the next 6 months that you don't even walk into the dentist office without a negative swab, and they don't either. And so if you have no active, honest, like dental work that really needs to be done for a couple more months, you might want to just, and also imagine if Minnesota finally goes down to here, like that theoretical that I said, then we're like all back to being normal. That would be huge. So I think if you've got some sort of dental pain or something's going on right now, absolutely get in there. I wouldn't have said that 2 months ago, but I think they're way better now than they were. And if it's just like you're 2 months behind on your cleaning, you might just want to wait a couple more months and we might be even better then.
Great advice. Um, Maybe one last question here, and this goes back to not just vaccine, but treatment. Knowing some of the, potential antivirals, some of the steroidal stuff, even monoclonal antibody, et cetera. Those kind of categories. Could you say maybe a couple of things I think one of the goals is, could this just be the equivalent of a common cold? Uh, and
Oh
two,
yeah.
and two, uh, does our community, the heart failure transplant community, uh, is there a ranking system on who gets that stuff first?
And like, would you guys get a ventilator if you came?
Not even event, although that's an interesting question. But some of these potential treatment trials,
Yeah,
vaccine
you guys might be
trials.
excluded on some of them, honestly, but things are moving very, very fast. So there's a couple of combination trials that have been pretty encouraging recently, and I just wrote a couple of them down. One is like a high dose steroid early in the course for somebody who's hospitalized, as well as something called tuzluzumab, which is sort of a immune system modulator, and then a different ventilator strategy. There were 0 deaths in that one. So there's a couple of like combination therapy things that are showing some promise and early data. Um, but I do think that usually for a lot of the stuff that we're testing, having prior transplant is sometimes exclusion. That being said, there is some compassionate use, convalescent plasma and some other ones. There are some compassionate use, open label, FDA approved, where we're able to sort of give stuff even if it's not within a clinical trial setting.
Got it. Great. Okay. I think one last question comes from Dan. Uh, is it reasonable or unreasonable to think that transplant patients could truly have antibodies for COVID-19?
I don't think they have any antibodies to COVID-19. I don't think that there's any sort of cross reactivity to a prior cold virus or
No,
anything.
but could we develop them as the general public would?
Oh, yeah, it's a good question.
Yeah. Yeah.
Yeah, I mean, like, will the vaccine be as effective? So, like, when we think
Yeah.
about the vaccine trials, one of the pushes right now is to make sure that we are having a inclusion criteria that's going to look like the people who need uh, so we want to make sure that there's obese people with diabetes, chronic conditions, African Americans. We want to make sure that there's a breadth of people in the vaccine trials to make sure that the vaccine really will work in vulnerable populations. I really don't think you guys are going to be part of the vaccine. It's going to be really interesting to see when the vaccine comes out. We're going to want to get it to vulnerable people first, but that's probably going to be the area where we have some of the least testing. I would expect that as the vaccine arrives, it might be that we are going to be measuring antibodies in you guys before and after. And I think probably even sooner than that, we'll probably have some evidence in transplant patients on some serial antibody testing. So I think within the next 6 months, we're going to have a population of transplant patients where we say, like, did they actually mount like the right response to the virus or not? We'll probably know more about that in the next 6 months. But this concept of herd immunity, if the whole population gets the vaccine, the transplant patients will be by default protected.
Got it. Great. Well, thank you again for the time. I know we went long, but appreciate all of your insights. And I'm going to take you up on your offer to come back and see us maybe.
I'll let you know how it went with Dad. Hopefully he's not hospitalized at Bethesda.
No.
I'm going to try to be really careful. So good to see all you guys.
Yeah. And thank you all for joining. And yeah, have a great
Lunch with Cogswell.
There we go. Lunch and learn with Cogswell. We'll see if we can't get everybody back together again. Thank you
Okay.
again.
All right.
And thank you everyone for joining.
Okay. All right. Bye.
Bye.